think we've got most of the folks who've joined. So let's get started. It is absolutely my pleasure to introduce my friend Tim Kaya. Tim is SVP for Optum Care, and as such is responsible for network contracting standards, the physician experience practice portals, workflow interoperability, and payment integrity. I wish I could list all of Tim's accomplishments. It would unfortunately dwarf even a 50-10 companion guide. But I will say that, and I still, I'm shocked to hear this. Tim's been with United Healthcare for more than 35 years. That's just amazing. Prior to his role at Optum Care, Tim was SVP and Chief Operating Officer of United Healthcare Networks, responsible for managing and developing contract management and fee schedule development, systems, workflow, interoperability, and operations. Tim led the charge for both 5010 and ICD-10 deployments and other affordable care administrative transaction requirements for the healthcare group, while promoting the principles of admin simp and interoperability. And I know Tim as, I'll use one word, and that is innovator. He brings to the table a passion for change and for improving processes for healthcare providers and payers. So with that, Tim, my pleasure to introduce you to the WEDI audience.
All right. Well, thank you so much, Rob, and right back at you. Been a great friend and colleague over the years. So I'm delighted to be here, and I couldn't really think of a more relevant topic at this time for us to talk about. I think, as Rob mentioned, my name is Tim Kaya, and I am with United Health Group and have been for some time. And my role right now, as Rob talked about, is really more innovative in nature to help the healthcare system actually optimize and work better. So let's go on to the first slide. I think we can everybody can see the disclaimer here, but I'm going to spend the next 30 minutes or 25 minutes here really taking us through a viewpoint on AI. And it kind of starts with how do we see healthcare in the next 5 years? And I don't think any of this is going to surprise anyone on the phone here. It's about being increasingly virtual, just like we are right here, increasingly delegated and value-based, increasingly digital, with this proliferation of what we see as how to use structured and unstructured data effectively in the workflow and growth of retail-centric care. I think you see just about everybody jumping into that side of the house. Very different than 5 years ago. Movement towards collaboration in data and clinical tech stacks, and actually combining clinical administrative data together in terms of the payloads that are going to make a difference in redirecting or directing care. And then this concept of payviders and consolidation. We're seeing an amazing thing happen in our industry from the delegation and value-based nature of where we're headed to those that are providers that are also payers. At Optum Care, we're a provider and a payer together, and the acceleration of new players in the field. And then payer alignment, I'll talk about this at the end, of removing unnecessary administrative burden. So just like, since I have a long history at United Health Group, just like there was a right time to normalize paper with the introduction of the UB82 and the HCFA 1500 back in the, I think, very early 1980s, there was a time to bring EDI standards to bear and all the X12 work that happened to do that. And there was a time to increase the use of portals and get out of phone calls and the like. But now is a different time. We are clearly in a moment of change, one that I don't even know 18 months ago we could have said, an intersection of technology, payment models, COVID helped us get there, provider readiness, and market forces really all coming together to help accelerate change in our industry. And it's all underlying higher expenditures in healthcare, pharmacy costs, and of course, an aging population. So let's go on to the next slide. I'm going to try and present a little bit of a viewpoint from United Health Group on the path forward to a next generation health system. You know, we see a number of things that can be put in place. For the most part, all building on much of what is already in place inside of our industry today to create and innovate around a modern, sustainable, high-performing healthcare system for really all Americans. So let's go to the next slide, and I'll start the outline of that. And this should help ground us for the rest of the conversation here today. So the path forward really outlines a series, and it's not necessarily even unique to United Health Group. You know, our view on achieving universal coverage, improving healthcare affordability, enhancing the healthcare experience, and driving better health outcomes. And let me just spend a minute on each one of these. So if you flip the slide and we take a look at universal healthcare, today approximately 30 million, I think, uninsured that's out there. And how do we begin to solve around that gap that exists there today? And on the page here, you see a suggestion around that. There are 7 million people eligible for Medicaid coverage today, 2 million more if all the states expanded Medicaid. There's 10 million folks out there eligible today for financial assistance and exchange coverage. And then another 10 million who are eligible for employer-sponsored insurance that may not have it today, and some things around unsubsidized individual coverage. But together, all of those things, if in fact could be put in place, could help us close the gap to achieving universal coverage here in the US. If we go to the next slide and take a look at improving healthcare affordability, some things here, and this is really, I think, obvious to everybody probably on the call, but accelerating value-based care. On average, every person in the U.S., we spend about $11,000 on healthcare annually. And by modernizing Medicare and Medicaid systems, we think there's a $1.5 trillion that's out there in savings by accelerating value-based care models. And as I think about it, you'll hear in the rest of this presentation that many have stepped on these hot coals before, and now we're all going to do it again. And I'll outline a little bit about why what has to change in order for us to get there. And then eliminating surprise billing. On average, $250 per person annually, $40 billion that's out there. And shifting care delivery to reduce consumer out-of-pocket costs to the right. I shouldn't say the right, to a different or a better site of service or site of care. So if you flip the slide to enhancing the healthcare experience for consumers and for providers, we think about empowering consumers to make more informed decisions. We're at this stage in healthcare delivery where there is so much more that we can put in front of consumers in terms of choice as they're with their physician. The combination of the work that we have with other EMRs and EHRs that are out there in order to deliver choice to consumers so they can make more informed decisions, getting more information in front of consumers about their past clinical history, if you will. Standardizing quality measurement and tracking, and for those of you in that business, it's a difficult business for all of us to be in, to comply with and get good at quality measurement and tracking. And then lastly, investing in the healthcare workforce, 500,000 physician shortage inside of the United States, and investing in a more diverse healthcare workforce that's out there. So if we take a look at the last slide here around developing better health outcomes, this is one of those moments in time where we see the industry being ready. Rewarding high quality, cost effective care. I'll spend a little bit of time on ACOs and why in the past ACOs may have only delivered 1% back into the marketplace, and those that are successful, there's a clear recipe that sits behind it. We also believe that integrated care delivery models deliver 40% lower costs on average in terms of producing health outcomes. And then lastly, improving data flow and health literacy really to everyone that's out there. So let's flip the page a little bit here and talk about AI. So if we can go to the next slide here, responsible use of AI in healthcare, and I took some of this from an Optum data science conference that was done back in the beginning of April this year. And just if you go to the next slide here, just a grounding on what is AI. Basically, the definition of it, you can see it in front of you. It refers to a set of computational methods that allow computer systems to function, think, and learn, and make decisions automatically about how to complete tasks that normally require human intelligence. That's pretty scary at the end of the day, yet we're all in that ship right now around how to exacerbate, if you will, AI in our business. Some examples of AI, it's speech recognition, virtual agents that are out there. We see it all over, not just the healthcare industry, but in every block of how we live our lives today. Machine learning, deep learning, graph analytics, which I find absolutely amazing in making recommendations, particularly in networks, neural networks, image recognition, which we all are part of today on our phones, and then NLP, which has come just a long way. All of these things, it's just a bunch of examples here, but all of these things are proliferating inside of our industry today. There's a ton of investment going into each of these, and a lot of competition that is emerging just relative to those examples. So if you go to the next slide here, what is the role of AI in healthcare? Should it replace human judgment in healthcare? Obviously the answer is no on that, but can it assist? Can we be more consistent, more accurate, more fair in replacing idiosyncratic human judgment with numerical models? The answer to that is probably yes, most likely yes. Eventually, and this is in development already in many of our organizations, it'll assist in predicting disease, high utilizers, and readmissions more accurately and in more real time, allowing the healthcare system to intervene with high risk, high cost patients. But will the doctor of the future be a robot? If you go to the next slide, clearly not. There's a perspective on this, and a perspective around AI in healthcare being called augmented intelligence as opposed to AI, as we just described it on the previous couple of slides. So augmented intelligence infers the use of AI methods to enhance and scale human clinical decision making rather than replacing it. So let's go to the next slide and talk a little bit about what this means. So, how do you enhance and augment? And the key word really is enhance and augment here in terms of getting to scale. You can see a number of examples around here, and I'll go through a couple of these as we get into a number of the next slides. But clinical decision support, clearly, when you take a look at the AI components of clinical and clinical quality, it will play a big role. Predictive models of disease risk and progression, the front end of healthcare, and I won't go through each of these that you see on the page here, but there's no question that the investment in these items continues to proliferate, and we're going to continue to see it proliferate. There'll be just a ton of options out there for us. Relative to efficiency, kind of a big deal, since we look at, and I'll talk a little bit about this in a minute, but the amount of time that is spent in administrative tasks, and Rob is probably grinning as I talk about this, because we've talked about this for the past 15 years around administrative costs in our business and why can't we get better at it. But now we have a lot more than we've had in the past in order to get better at it. When you look at some of the things that are on here relative to identification of fraud, waste, and abuse, instead of employing thousands and thousands of people to do this, we can do it through AI in the right ways, and simplifying workflows to enhance the provider and the patient experience. There's no reason why we can't do that today. We have all the tools to do it today. So if we can go into the next slide, I want to talk just a little bit about the challenges. Everything about AI sits on the data that it consumes. And across our industry, if there's one thing that we have to get a lot better at, it is about the data. Because the data is going to break or make the work that we're doing here. Fractured data around clinical data, we all know it sits that way. There isn't really a single system that can give the clinician all of the data that they need in order to be firmly confident in the results that some of these models are putting out. You're pretty confident, but when you look at the things that are on this page here, all of this stuff has to come together, and I think, as we all know, it's not all together today. We're making efforts to get a lot better at it, but it's not together today. So that produces a big challenge for us. If you look at the next slide here, around, again, incomplete or missing data, add to the picture things that we probably really haven't spent a lot of time on, but are becoming increasingly more important. The mental health side of things, the economic stability around an individual, the neighborhood they live in, the education that they have. We'll see, and we'll have to talk about the biases that exist in data that produces the models that we're going to be looking at in the future, requires us to think about these sorts of things as we develop our models of the future. So looking at the next slide here around, again, around healthcare data challenges. For those of you that are in this business, it's interesting to see healthcare data sets that are skewed towards those groups, existing groups such that may or may not have access to adequate healthcare, lack health insurance coverage, lack available services, or lack culturally competent care. We need to keep these things in mind, and we also need to keep in mind the small sample sizes that are out there in order to produce the statistically appropriate. In essence, AI is a math model. As you all know, as you get further and further into some of these studies, it gets more and more difficult to get sample sizes that can be normalized and then fed into models. So that leads me to this next slide, which is really just a statement. Like sausage. Sometimes we don't know what's in it, but we all consume it. So as responsible members of healthcare community, becoming educated of the data that we consume will become more and more important in the future. So I'd like to take this next slide here and just conclude around the responsible use of AI. You could talk about this for a long time, but the accountability, those that are producing models and then feeding them into the healthcare experience, the accountability around the quality of the data, the normalization of the data. In almost every one of these here, you'll see the underlying data, and understanding, clearly communicating the strengths and limitations of the data as we produce models, transparency around where that data came from, the fairness question around health equity, and the exasperation and introductions of bias in data as it exists today, being aware of it. And then lastly, just almost in summary, being proactive around the responsible use around, just like we just talked about, acknowledging the limitations of data, addressing the sources of bias, inappropriate use of models, preventing it, and then promoting fairness and health equity. So I saw a question pop up on that, and if I didn't answer that at the end, we'll come back to it. So let's advance here and say, what are we going to do about it? So what can we do about it? If you go to the next slide, and there are clear implications to both administrative and clinical efficiency. Some more current or easy to get at, if that's the right word. Some more difficult to get at for some of the reasons that I just talked about. So let's first take a look at administrative improvement. If we go to the next slide here, we spend today, on average, if we can just advance to the one more slide here. There you go. We spend today on average $1.1 trillion in the healthcare system annually on administrative costs. That number is expected to grow to 1.8 trillion by 2027. And if you look at just the BIR, which is the billing and insurance related costs, 245 billion of it is waste. Now, for those of us that have been in this business for a long time, we know where it is. We have an opportunity now to do something about it. Claim processing and payment accuracy, billing payment and reconciliation, coding and documentation, eligibility and coverage, all amounts to about $245 billion inside of our industry. And if you look underneath here, then while it might be hard for everyone to see, can you still hear me? Because right now I got a note here that the audio stopped.
Yeah, we can hear you. Yeah.
Oh, okay. Yeah. Let's move to let's stay on this slide right here. And annual administrative waste. There's a little bit more detail here, and I think we can send some of this out about where the waste actually is inside of our industry. But as we look at next steps here, there's some clear next steps. I mean, there's no question in our industry that we have to get our hands around the attachments and the rules around attachments to create some sort of normalcy around how attachments flow back and forth. Everybody's working on prior auth rules, the automation of prior auth, the rules around prior auth and eligibility and benefits, and the payload that's associated with eligibility and benefits, even outside of the 270 and the 271 response that's out there. But examples around listening technology and NLP, automation and coding, we see that happening today, and it's getting better and better. The ability to create a claim right out of the EMR or the EHR, putting edits in the EDI stream and what we would call shifting to the left, which is let's put the right clues in the EDI stream as we're creating the claim and submitting the claim rather than waiting for the denial to happen 10 or 15 or 30 days later. Bot-enabled processing, graph technology to recommend networks. So while we all have networks, if we're payers inside of our business, a network can actually sprout up just relative to the type of care that the patient needs, the most efficient and effective network that's out there. We've got the technology to do that today. And then just relative to core connectivity, the core from CAQH connectivity update, and bringing REST capabilities inside of X12 transactions becomes really important. So I'm gonna, just in the interest of time, I'm gonna skip the next slide because it gets into, if you can go to it for just a second, it gets into, there are so many opportunities that we see happening at pre-appointment, pre-service, at service and post-service, and post-payer for us to integrate AI in. There is just so much fun stuff to actually do. Let me shift gears to the clinical platform for a minute. And if you go right away to the next slide, as we look at significant opportunity for clinical enablement, what we see is $500 billion in healthcare spend that's waste that's expected to grow to $900 billion by 2027. The bulk of it, if you look at this step graph that's up here, $321 billion is there for introducing clinical decision support into the workflow. You'll see a lot of that at the bottom of this slide, but getting normalization of data in order to introduce clinical decision support in the workflow will take out more than half of that $500 billion doctors, or $500 billion in waste. And it's important for us to work closely with our EMR and EHR partners, help physicians and clinicians who spend time spend time documenting things. If you ever spend time watching this, you know that there's a flurry of opportunity there. So let me go to the next slide here, and we'll just go through the foundational steps around clinical improvement, because there's a good deal of detail here around where that waste is in the $518 billion. But think about NLP, clinical standards, adoption leadership, which I'm going to come back to and discuss in a minute here. But many digital steps to improve. And I think many of us are engaged in these sorts of things that are getting better and better with time. Again, with focus on keeping clinical care guidelines, or pushing clinical care guidelines into the workflow, all based upon the right sort of data. So this next slide, I'm not going to spend a bunch of time on it, but it goes into data, just like the administrative side, around what does it mean around data collection, curation of that data, content and analytics, and then delivery of it to the workflow. So there's an example on this page that you can read through around a patient's journey around how can we make healthcare more efficient clinically. And then the last topic here, really before I get into leadership, if you go to the next slide, is around the implications of always doing what we've always done. There's this burnout notion that we all hear about inside of our business, and the reasons for it we much more clearly understand now. And everything that I'm talking about gives us ammunition to address these sorts of things. Paperwork and administrative things that are happening represent 42% or 43% of the source of stress of a clinician today, and there's a number of other ones that are on here. The notion of how do we fix this is borne out in many of the things that we just talked about. So let me go to the last slide here on burnout, because I know I'm running out of time. And we, when you look at this and this bottom box here, replacing one physician, at least our experience of replacing one physician who leaves prematurely, costs our organization $500,000 and $1 million in recruitment, training, and lost revenues. It's really important for us to address that, because that's all waste inside of our industry. So the last thing that I want to hit on here before I let you all go is, at the next slide here, is the importance of leadership. If you can go to the next slide here, on creating change. And this last slide here, we have to ask ourselves, and many have done this, why have we not been able to make progress to date, or the progress that we want to make? Clearly, our time is now. A number of the different health plans has spun up with the help of Audacious Inquiry and CAQH, this thing called the Healthcare Interoperability Payer Collaborative, where we all address the things that are administrative duplication that's out there, where we can all work better together to help the healthcare system. The first use case on that is payer-to-payer data exchange, so that we're not going out and pinging every payer from every provider in very different ways. CAQH Core is helping us around that, and the folks over at Audacious Inquiry are also helping us get there. But this committee, presuming successful with this first use case, has a lot of promise for us to take many of the things that happen technically in our industry and bringing them forward to implementation and adoption inside of our industry. So with that, I'm gonna stop. I know I'm 2 minutes over, Rob, and see if I don't think we have much time for questions, because I know you guys have another session right after this.
Well, Tim, that was just fantastic. I think we could spend the entire conference going through your slides, because you've hit on every key issue, I think, facing healthcare. So thank you so much for sharing your thoughts. And with that, I will turn it over to John to introduce our next speaker.
Actually, Rob, we're going to be moving, folks. We're going to be moving from this session to the session regarding with Dr. Viet Nguyen. It's starting momentarily.